So in this case, given to me by Dr. Testori, we have an advanced periodontal disease case. Some implants have been already inserted on the lower jaw, but most of the teeth are going to be extracted on the uppers. So this is the time of the extraction with implant placement with bone graft, guided bone regeneration, and connective tissue graft. So first of all, we do an atraumatic extraction. And when we want to sound the bone, as we explained at the beginning, it is important to sound the bone after extraction. We can detect bony fenestration on the socket of tooth number 12. The periodontal teeth were extracted and the full thickness flap is reflected. Now we can put one implant on the palatal site, close to the palatal bone, to leave the gap on the buccal. This gap is going to be filled by bios, and on top of that gap, because we had some fenestration, so it was easy to add a lot of bios, and we know that it is necessary when we put allograft or autogenous graft to put a bioguide material, any membrane, a double layer here to give us more time for resorption, and on top of this we are going to place a connective tissue graft, so that will increase not only the thickness of the site but also the thickness of the biotype. Then the rest of the surgery is a normal one. The choice was done of putting some implant and putting some Pontics. Then the case was left for a few months for the tissue to heal before doing the exposition of the implant. Then this is the case before the final restoration, but you can see that on the site where we have put our bone graft, membrane, connective tissue graft, that we have a nice tissue here, a nice bulk of tissue. And this is the final result of this very important restoration, combining teeth and implant. That's the case. You saw the flap design where we were starting with the tooth having a fistula, and it was not possible to put an implant at that time immediately. So we let it here for 8 weeks for the tissue to cover totally the alveolar socket. So when the tissue was thick enough, we decided to make a vertical incision, taking the papilla on the adjacent teeth, the distal papilla on the adjacent teeth, and a palatal crestal incision on the occlusal site. Not willing to wait to the final integration of the implant, because we saw that the thickness of the ridge was not enough, we decided to make a circular incision on the proximal teeth and a palatal crestal incision. It was giving us the opportunity to remove the cover screw. So not waiting for the final osseointegration to occur, I decided to raise the flap because we did not have as much thickness for the ridge. We have removed the cover screw, take the opportunity to have an impression taken, and plug here in this envelope flap a connective tissue graft. And that gives us a fantastic opportunity to increase not only the thickness of the ridge but also the quality of the biotype. So this biotype definitely is more resistant, even though it's going to retract, as Grunder is saying, by 0.61, but we have done such in excess augmentation of the tissue that even though it will retract, we still have enough. Then we took the final impression, we put the abutment, and this is the final result. The final result show what? That we have two things here. The level of the gingiva is exactly the same on both teeth. Number two, we have a very large interproximal papilla, central papilla between the two central, and if you look to the X-ray, my implant is slightly more toward the lateral, so I have maintained more bone, interproximal bone, to give more vascularity to this papilla. Looking to the palatal site, the tooth is very thin, has the same diameter like the natural tooth. So the patient is not disturbed when he speaks or when she speaks. Now comes the time where we need to put a connective tissue graft after implant exposition. It happened like here that unfortunately when we expose the case we did not have enough tissue, enough bone, the ridge is deformed, we have a depression, especially on the lateral, and some maybe exposition of the cover screw of the healing abutment. So here, when you draw a line, we can see definitely that we have two depressions, one on the lateral on the left, one on the central on the right. Lateral on the right and the depression on the right, left central. By going to the tuberosity, we take a large piece that we cut in two pieces, and we are going to plug each piece in the depressed ridge. And you can see, after the work of Dr. Okawa, who is a fantastic restorative dentist, we have a beautiful result with harmonious contour and bulky contour. So we change the biotype by adding connective tissue grafts. This case that you will see at the end of my presentation took me 15 months to achieve, to go from the picture from the initial consultation to the last one, when you can see the level of the tissue is in very good harmony with each other. If we go to this case, we are dealing here with a depression following an immediate implant placement and a restoration which is very bulky. So we have a depression on the ridge and we have excess of contour on the restoration. So we have what we call a compromised aesthetic and umbrella effect. So we decide here to remove the old restoration, to remove the old implant abutment in metal, combination of gold and titanium. And we can see that the emergence profile was very limited in height. We have less than 3 millimeter, and the thickness of the tissue is less than 1 millimeter, which, as we know, should be more than 2 millimeter to obtain an aesthetic result. The temporary crown is prepared, and we are going to use some very small, sharp micro elevator to plug this instrument inside the buccal between the bone and the buccal gingiva to design this pouch, mesio-distally, to create this wide opening where we are going to plug our connective tissue graft. The connective tissue graft is harvested, and we keep all tissue. There is no need, in fact, to remove the fat tissue from that graft. The thicker it is, the better it is. Now, it is important to understand that we want this full, important graft to be inside that pouch. So we use a very long needle. So we go on the mesial corner of the implant. We get out from the gingival margin through the pouch. Then we take the mesial corner of the graft and we start pulling this graft up in the pouch. Then we do the same thing on the other side. We take a long needle, plug the distal part of the graft and pull it up in the distal pouch. When we have totally stabilized and harmonized the position of the graft, then we can definitely suture both sides, the mesial and the distal side. And we have now a nice bulk of tissue. We put the temporary crown. The position of the implant was not the best, so we end up having here a hole in the buccal, so we put a composite. But at the end, after a few weeks, we end up having 3.5 millimeter of soft tissue around the implant. So that gives us a lot of possibility to work on the emergence profile. So we are going to change now the contour, the subgingival contour of the restoration, of the abutment and the restoration. We don't like the bleaching of the tissue to go beyond 5 minutes, mean that if we leave it this way, the tissue will go up. and we just adjust with that. And Dr. Hoover have done the temporary crown and have obtained this beautiful result with a nice contour, harmonious contour between the implant site and the adjacent teeth. Then it is time to work on the abutment by making concavity of the abutment and making a very thin emergence profile for the ceramic crown. And we can see on the final result that we have a beautiful harmonious contour with beautiful papillas. There is just tonicity from the crown giving the normal contour and nice shape for the restoration. Now comes a case where it is a complication because of the bucco-palatal position. The implant was inserted too buccally, so automatically the bone was grinded or resorbed very easily, and we end up a patient having a crown with some acrylic mask, I would say, to compensate the depression of the ridge. So this is an extreme case that I will not do on a regular basis because it's going to be a long process. So we start removing the old restoration with the resin appliance. Then we are going to put a new abutment, having a very concave abutment, submerged concave abutment. We put a new temporary crown. We let the tissue heal, but it does not go to the point we would like to reach, unfortunately. So we need now, at this stage, to make a flap, a full and partial thickness flap, to harvest some connective tissue graft, and to advance the flap coronally on this connective tissue. We let it heal for a few months. We do have a better result than before, but it is not sufficient. So we have the choice to make another connective tissue graft with another advanced coronary flap, or another technique developed by Rosenberg in the 80s, showing that we can move the whole quantity of tissue around that implant by doing circular incision, by doing an horizontal incision down below the mucogingival line, plugging in that pouch a new connective tissue graft, and now we have suspensory suture, vertical suspensory suture, to maintain everything in place, all this entity of tissue down. And the end result, yes, is nice. We are at the same level on the natural tooth and on the final restoration. And this is the result after 3 months, thanks to Dr. Okawa, who is a fantastic restorative dentist. Now, we finish with the temporary final restoration, which also work and have their enormous influence on the soft tissue. And I show the case that you showed before for a few slides. A patient from San Francisco lost one tooth, was referred to Paris by one of my referring dentists, and we decided in that case, even though we had a very limited thickness of crest to be able to obtain good stability of the implant, before doing that we draw some blood from the patient to take some factors from the blood, PRF factors, and we are going to mix these factors to the bone graft that we are going to put on the implant surface, which is exposed because of the minimum crest that we have. And then on top of that, instead of using a membrane, we are going to put 2 membranes of these PRF growth factors. Then we make a coronary advanced flap to cover nicely all the things we have put under the graft, the implant, the bone graft, the PRF membrane, etc. We let it heal for 2-3 months, and we find out that yes, we do have done an improvement of the situation, but still we need something more. So we decide, instead of raising another flap, to plug this time a new connective tissue graft that we take with a very large tissue punch, where we remove after that from the palate the junctional epithelium, the epithelium. So we have now a connective tissue graft, and we plug this connective tissue graft below, down the crest. We let it heal, and a few months later we decide to expose the implant by making a triple incision, very specific design, and we are going to remove also the epithelium at the base of the palatal incision to be able to roll the tissue to increase the height and to decrease the level also of that tissue. This is the healing, 6 weeks post-op. In the meantime, we have received from the lab the temporary crown, the abutment guide for the zirconium abutment, the Procera shell that we're going to try. But as soon as we put the abutment, we find out that the level of the gingiva is very high, that we have no papillas, and that we still have a lot of work to do. But thanks for what we learned on the submergence profile that we can obtain from the temporary crown, we can see that after 2 weeks already things seem to be better, and as soon as we start putting a concavity on the emergence profile on the buccal of the temporary crown, the tissue start thickening and become even down below the level of the adjacent tooth. So now we just have to wait for this tissue to mature. It could take 6 weeks, 3 months, 6 months. The time works with us. And when we find that definitely the tissue is thick enough, and that took 3 months after the second surgery, the exposition of the implant, then we took the final impression. We modified slightly the preparation to put it below the gingival margin, and we receive, with some instruction given to the lab technician, a concave submergence profile with a depression on the enamel, on the restoration, to obtain the same type of deformity that we have on the enamel on the adjacent tooth. And this is the result that you can see at 6 months after cementation. So we have 2 teeth we look the same, with the same shape, color, and the same gingival coronal deformity. In other words, you can, if you want, modify the shape of the gingiva just by modifying the temporary and the final restoration. So this is initial slide, and this is 15 months after all this work done on this patient. It is important to remember a few rules, like trying to put the abutment as soon as possible and not having to disconnect it several times, because every time you disconnect it, you are tearing the hemidysmosome, and the junctional epithelium will grow down and the bone will resorb, and you end up having gingival recession. There are some prosthetic recommendations. It's better to have a customized abutment with juxta or just 0.5 millimeter from the gingival margin, so there will not be any cement trapped inside, which will be some complication. Don't forget to decontaminate any product coming from the lab, and maintenance of the patient is very important. This patient should be considered as normal patient and should come for maintenance on a regular basis, because inflammation is part also of the recession. As a conclusion, we can say today that we can work with scientific-based key to success in aesthetic implant dentistry. There are 10, and I do thank Dr. Maurice Salama for giving me these slides that I have modified a little bit. Each one has given a little stone to this scientific keys, I would say. So today we know so many things that if we respect all these things, we will prevent making mistakes and we can achieve beautiful results. We know the factors: anatomical, surgical, prosthetic. So if we respect these different factors and we make some delicate surgery, we know where we go. As I said before, the final image should be on your mind from the first consultation. If you know where you go, you can achieve what you want. Today, I can conclude by saying that implant dentistry is becoming like conventional restorative dentistry. We have a case after periodontal surgery. We let it heal. We put some laminate veneer. The papilla are there. It's a beautiful result. Prosthodontics is TLA. And today, as I said, if we respect the different biological parameters, if we use the right implant with nice body, colors, surface, if we know how to handle the abutment, we can prevent and reduce crestal bone loss. We can increase and stabilize the volume and the level of the soft tissue. So it is important to work as a multidisciplinary team in a way. A good surgeon, a good restorative dentist, a good lab technician, a patient who is able to understand the amount of work that we have to put in order to achieve, on some cases, difficult cases, all we have to do. So this concern and trend should be part of the awareness of this multidisciplinary approach to get a beautiful result and harmonious result. I'm advertising maybe the book. Why not? We published 4 years ago The Art of Smile, where I wrote a chapter on periodontics and a philosophical article on the smile, the importance of the smile. And in October 2009, we have another book, The Art of Treatment Planning, where this time I wrote a very important chapter where you have all these 10 multifactorial factors developed in detail. And you can look after the lecture to this book and you find much more reference. You have more than 200 references.